So, as we know, peripartum cardiomyopathy represents a unique pregnancy-associated form of heart failure that occurs in previously healthy women and carries a substantial risk of maternal morbidity and mortality. So despite increasing awareness and improvements in outcomes over the last 2 decades, peripartum cardiomyopathy remains a major contributor to cardiovascular-related maternal deaths globally, and particularly in regions with high burden disease, such as the sub-Saharan African district. The aim of this talk is to provide a comprehensive and clinical practical overview of peripartum cardiomyopathy. And just having mute. Um, so Thank you. So what we will do is we will go through a short clinical vignette, and then we will jump into a detailed discussion on the definitions, epidemiology, pathophysiology, clinical presentation, and management of peripartum cardiomyopathy. Good. So our case that we will be discussing tonight is 27-year-old Miss N. She is gravid to para 3, currently at 37 and 5 weeks gestation, according to early ultrasound that was dated at 19 and 6 weeks. She's got a background history of an RPR that was negative, retroviral disease that was negative, and RH positive. She's got a BMI of 29, a previous NVD that was uncomplicated, and this current pregnancy is known with a set of DCD8 twins. Of note, she's got no pre-existing medical disease. So this lovely lady presented to a labor ward from home with a 1-day history of acute onset shortness of breath. On arrival, her vital signs revealed that she had acute severe hypertension with a blood pressure of 165/111, a pulse of 180, saturation of 80% on a 40% FiO2, a respiratory rate of 44, and trace protein urea on her dipsticks. Of note, on her clinical examination, she yielded bilateral basal crackles were found on examination. Cardiovascularly of note, she had a displaced apex. S3 gallop was audible with no murmurs noted. The diagnosis of a type 1 respiratory failure with severe metabolic acidosis was made on arterial blood gas with a pH of 7.24, a PO2 or a PCO2 of 3.8, a PO2 of 8.2, a lactate of 7, bicarb of -15, or base excess of -15, and a bicarb of 14. A chest X-ray was ordered, and as you can see on the right-hand side, she had an increased cardiothoracic ratio and noted pulmonary congestion. The assessment at this point was that this patient was in pulmonary edema with a concern of an underlying cardiomyopathy. Subsequently, a transthoracic echocardiography was ordered for her, and of note of the report was noted that she had a left ventricular ejection fraction of less than 20%. No left ventricular thrombosis was seen. The left ventricle was severely dilated with impaired systolic function, as well as diastolic dysfunction with elevated filling pressures. You'll also see that she was noted to have a mild tricuspid regurgitation, as well as a mild mitral valve regurgitation. In the absence of pre-existing heart disease in this patient, the diagnosis of peripartum cardiomyopathy was made. The initial management of this patient included transferring her from our level 2 to our level 3 facility, and she was admitted in a critical care unit. Management from the start was that we decided to keep her NPO from a fluid standpoint. Analgesia, she was not offered any at that point. No sedation. In terms of thromboprophylaxis, calf pumps was initiated. She was cared for in a 30 degrees head up position. For ulcer prophylaxis, we initiated pantoprazole 40 milligrams and ordered 4-hourly glucose monitoring. As the initial management plan, Lasix stat dose of 40 milligrams was ordered and then scripted as a 12-hourly dose. Morphine 2 milligrams given for her. Magnesium sulfate infusion was started for the acute severe hypertension that she had, and was decided that a labetalol infusion would be warranted if she has any further acute severe hypertension episodes. Intermittent CPAP was started for her with a PEEP of 8, pressure support of 12, with a FiO2 of 50. It was decided that we're going to start on ceftriaxone and azithromycin cover to cover for any possible infections. And the delivery plan was made that she's going to be for abdominal delivery once the patient is stable and anesthetic review taken place. Patient was started on intermittent CPAP with 40 milligrams of Lasix as scripted. The patient actually improved on intermittent CPAP with a respiratory rate that decreased from 35 to 19. Saturations on 80% FiO2 saturation of 80% on FiO2 went up to 96%, and she had a heart rate that decreased from 148 to 119. At that point, the emergency abdominal delivery was scheduled. It was an uneventful cesarean section with an estimated blood loss of 450. It was a set of twins with twin A being 2.4 kilograms of APGARs of 9, 10, 10, and twin B also of a weight of 2.4 kilograms of APGARs of 9, 10, 10. She was transferred back to the critical care unit, started on anti-failure treatment. Enalapril 10 milligrams was initiated PD for her blood pressures. Carvedilol was started by the cardiology team, and intermittent CPAP was continued. At this point, bromocriptine was discussed, but due to socioeconomic circumstances, not started. So that brings me to why is peripartum cardiomyopathy important? So cardiovascular disease complicates up to 4% of pregnancies worldwide and is now one of the leading causes of maternal morbidity and mortality. Among cardiovascular conditions, cardiomyopathies represent the dominant contributor to maternal deaths in high-income countries, and peripartum cardiomyopathy is the most important pregnancy-associated myopathy. What makes peripartum cardiomyopathy particularly devastating is that it typically affects young women with no prior cardiac disease and often late in pregnancy or shortly after delivery, when the time when physiological stress is at a maximum and diagnostic confusion with normal postpartum symptoms is common. Postpartum cardiomyopathy also clinically important because it's one of the few myopathies where there's a substantial chance of recovery, with approximately half of the affected women regaining normal left ventricular function and a further 30 to 40% experience partial recovery. However, delayed diagnosis and delayed initiation of appropriate therapies are associated with persistent ventricular dysfunction, thromboembolism, arrhythmias, and death. Importantly, the burden of disease is not evenly distributed, where women with African ancestry experience a remarkably higher incidence and worse outcomes, making peripartum cardiomyopathy a highly relevant condition in the African context. So, to understand why peripartum cardiomyopathy occurs, it is important to understand the cardiovascular adaptations in normal pregnancy. And to appreciate this, we need to remember that the cardiac output increases throughout the pregnancy and raises roughly about 30 to 50%, reaching a peak in the mid-pregnancy. This increase is driven by initial increase in the stroke volume and later by increase in heart rate, which typically rises about 10 to 20 beats per minute. The sharpest rise in cardiac output occurs at the beginning of the first trimester, and there's a continued increase in the second trimester. After the third trimester, there is debate as to whether cardiac output increases, decreases, or plateaus. But by 24 weeks, the increase in cardiac output is roughly about 45%. The maximum cardiac output associated with pregnancy occurs during labor and immediately after delivery, with increases of about 60 to 80% above levels seen before the onset of labor. This is related to many factors, including increase in heart rate, preload, and associated with pain and uterine contractions. As we know, there is a decrease in arterial blood pressures, including systolic blood pressure and diastolic blood pressure, as well as mean arterial pressure. At the time, systemic vascular resistance decreases due to vasodilation mediated by progesterone, nitric oxide, and other vasoactive substances. So from a cardiology perspective, the left ventricular wall thickness and left ventricular wall mass increases around about 28 to 52% above pre-pregnancy values throughout the pregnancy. Recently, MRI studies have quantified that about 40% there's about a 40% increase in the right ventricular mass, and studies in mice have also shown that there is temporary cardiac remodeling associated with volume overload, and ventricular hypertrophy is accompanied by upregulation of vascular endothelial growth factors. The typical transthoracic echographic findings in a normal pregnancy include mild four-chamber dilation. This is changes in the right atrium and ventricle are typically greater than that in the left, with transient trivial mitral regurgitation and physiological tricuspid and pulmonary regurgitation. So if we have a look at the definition of peripartum cardiomyopathy in the instance of our patient, it's a form of heart failure defined as a new onset of left ventricular ejection fraction reduction of less than 45% with or without left ventricular dilation, occurring towards the end of pregnancy or in the months after delivery in absence of any identifiable causes of heart failure or recognizable pre-existing structural heart disease. According to the initial definition, the peripartum cardiomyopathy onset ranged from the last month of pregnancy to the 5th month postpartum, but we have seen documentation of similar cases presenting before or after this time frame, and this has led to the broadening of the definition, which is now time independent. A critical aspect of definition is that peripartum cardiomyopathy is a diagnosis of exclusion. Pre-existing myopathies, ischemic heart diseases, valvular diseases, congenital heart disease, pulmonary embolisms, and other causes of acute heart failure must be reasonably excluded. So if we have a look at the epidemiology and in the African and South African context, we approximate that there is about 2,000 peripartum cardiomyopathies, approximately 1 in 2,000 cases, but there is a striking regional variation. As we noted in the slide, we can see that in Western countries, the reported incidence ranges between 1 in 1,000 to 1 in 5,000 pregnancies. But in contrast, we can see much higher rates are reported in regions such as Nigeria, where the incidence may approach 1 in 100 births. In South Africa specifically, as one of the highest documented incidences outside of West Africa, with approximate 1 in 1,000 pregnancies being affected. This high burden aligns with observations that women of African ancestry have a 3 to 16 times higher risk of developing peripartum cardiomyopathy compared with that of Caucasian women. Multiple factors like genetic susceptibility, higher prevalence of hypertensive disorders of pregnancy, socioeconomic determinants of health, and different accesses to care contribute to this number. Importantly, incidence appears to be rising worldwide, reflecting increasing in maternal age, higher rates of obesity and hypertension, and improved recognition. So a quick overview of the pathophysiology. So there was an early hypothesis that focused on hemodynamic stress alone. However, this was insufficient because the peak of hemodynamic changes, as we've discussed, usually occurs in the mid-pregnancy, whereas postpartum cardiomyopathy usually manifests in the late 3rd or postpartum period. So recent literature suggests that there is a multi-hit theory for developing postpartum cardiomyopathy with the accumulation of genetic and environmental risk factors. Vascular insults caused by antivascular hormone effects of late pregnancy and the early postpartum period induces cardiomyopathy in women with an underlying predisposition. So if we have a look from a genetic point of view, it is postulated that there's an overrepresentation of genetic variants that encodes for the sarcomeric proteins titin, myosin, and troponin. And it has also been found that up to 15% of women with peripartum cardiomyopathy have got a titin and truncation variant. And of all of the variants, the titin and truncation is usually the most common. The titin and truncation mutations were seen in about 13% of African women and 8% of Caucasian women, which could be one of the possible explanations for the worst prognosis seen in African women with this condition. From the prolactin point of view, there's growing evidence that several pathological mechanisms in peripartum cardiomyopathy converge on a single common pathway, which involves inflammation, unbalanced oxidative stress, and generation of anti-angiogenic 16 kilodalton prolactin. The 16 kilodalton prolactin induces endothelial dysfunction and damage and subsequently leads to heart failure. Though through unknown mechanisms, oxidative stress stimulates myocardiocytes to express cathepsin D, an enzyme that cleaves prolactin into its 16 kilodalton fragment, which then causes endothelial apoptosis, and capillary dropout. There is also a postulated placental angiogenic factors. So placental secretion of sFlt1 contributes to antagonizing vascular endothelium growth factor and placental growth factor, thereby impairing angiogenesis. So further suppression of protective factors like our relaxin-2 further exacerbates this effect. So sFlt1 levels are also elevated in preeclampsia and multiple gestation, providing a possible explanation for the strong epidemiological association between preeclampsia and postpartum cardiomyopathy. So if we have a look at our preeclampsia overlap, so this meta-analysis demonstrated, or this meta-analysis of 22 studies that looked at 980 patients demonstrated that approximately 22% of women with peripartum cardiomyopathy have preeclampsia, which is substantially higher than the background prevalence in the general obstetric population, which is about 5%. This indicates a strong association between peripartum cardiomyopathy and preeclampsia, and clinically this supports the concept that peripartum cardiomyopathy and preeclampsia are not independent conditions, but rather share overlapping pathophysiological mechanism, particularly related to the angiogenic imbalance and endothelial dysfunction mediated by factors such as sFlt1 that we have already discussed. So this data reinforces the importance of actively screening for preeclampsia in women with peripartum cardiomyopathy and maintaining a high index of suspicion for peripartum cardiomyopathy in women with preeclampsia who develop heart failure symptoms. So what are the risk factors for developing peripartum cardiomyopathy? So there are several observational studies and registries that were looked at by the set of researchers, and it has determined that ethnicity is one of the strongest determinants, and has already mentioned that women with African ancestry experience substantially higher incidences and worse outcomes. So statewide study conducted in the United States reported that African Americans are 3 to 16 times.
Sorry,
Hello?
we spoke about questions at the end. I just wanted to find out if so African and Afro-Caribbean, as you've said, is an increased risk factor. Is that independent of the African risk factor of preeclampsia? Do you have any insight, or possibly Dr. Hassim can maybe let us know at the end if that's an independent risk factor outside of having preeclampsia as a comorbid disease?
Sure. From what the research shows is that we think that it is all related to overlapping pathophysiology. So as we know that in our African population, our sFlt mediated placental insufficiencies that lead to preeclampsia is more predominant in the African context compared to the Caucasian context. And that overlapping pathway explains why the incidence of preeclampsia is so high, and why the incidence of peripartum cardiomyopathy in that subset of patients is also just as high. All right. If we continue, we can see that hypertensive disorders of pregnancy, particularly preeclampsia, are strongly associated with peripartum cardiomyopathy, and a further meta-analysis of 22 studies have shown that preeclampsia is present in about 22% of these patients, and hypertensive disorders in about 97%. Advanced maternal age, particularly over the age of 30, independently increases risk, and up to a 10-fold increase reported in women over the age of 40. So other established risk factors include multiparity, multiple gestations, obesity, smoking, diabetes, anemia, malnutrition, asthma, and a prolonged exposure to tocolytic therapy. The identification of possible risk factors in peripartum cardiomyopathy would aid in early recognition and prompt diagnosis and management. So if we have a look at the clinical presentation and work of peripartum cardiomyopathy, we can see that it presents in the same form as that of systolic heart failure due to other cardiomyopathies. So patients commonly present with dyspnea. Typical symptoms include a cough, orthopnea, paroxysmal nocturnal dyspnea, pedal edema, and hemoptysis. The initial diagnosis may be delayed, and symptoms such as nonspecific fatigue, shortness of breath, and pedal edema are similar to those that occur in normal pregnancy, but are more pronounced. So physical signs can include an elevated JVP, displaced apex, and a third heart sound, and a murmur of mitral regurgitation. If we take this in the clinical context of our patient, we know that she presented with acute onset shortness of breath. There was a raised JVP. She did have a displaced apex and a third heart sound, as well as mitral regurgitation was found on the echo. If we have a look at ECG, so the ECG abnormalities are found in about 50% of patients with peripartum cardiomyopathy, but a normal ECG does not exclude the diagnosis. ECG findings in patients with peripartum cardiomyopathy are nonspecific and can include a sinus tachycardia, nonspecific ST and T wave abnormalities, and anterior precordial Q waves and prolonged PR intervals. A chest X-ray, as seen in our patient, can demonstrate a raise in our cardiothoracic ratio, and we can also possibly make a diagnosis of pulmonary edema with pulmonary congestion. Echocardiography is a cornerstone to the diagnosis and should be performed in all patients in whom the diagnosis is being considered. And the echo generally reveals a global reduction in our left ventricular systolic function less than 45%. And in our patient, we know that it was actually less than 20. If we have a look at the diagram, we can see peripartum cardiomyopathy can be divided into our mild, moderate, and severe forms. And this is largely based on our echo findings, with mild peripartum cardiomyopathy having an ejection fraction of between 30 to 45%, moderate being 20 to 35%, and severe being less than 25%. So our patient would fall into the severe peripartum cardiomyopathy group. Differential diagnosis that needs to be excluded, as there is lots of overlap with normal pregnancy-related conditions and other cardiovascular conditions. So the differential diagnosis includes pre-existing myopathies such as familial dilated cardiomyopathy or drug and toxin-induced myopathies. Previous myocarditis, valvular disease, mitral stenosis, and aortic stenosis is among the common valvular abnormalities and can be unmasked by pregnancy. Congenital heart diseases such as shunt lesions and pulmonary arterial hypertension should also be considered. And we should also keep in mind that pulmonary embolism has a 10 times higher risk during pregnancy, and the postpartum and myocardial infarctions have a 3 to 4 times higher risk in the peripartum period. So because circulating plasma volumes and cardiac output increases by 50% by the late second trimester, and then for the plateau, the majority of pre-existing heart conditions can be unmasked during this mid-second trimester surge. So if we have a look at our diagnostic flow, so if we suspect peripartum cardiomyopathy, some of the baseline investigations is a natriuretic peptide. In our patient's context, the natriuretic peptides were not done as it is a very costly investigation to do. She had an ECG, chest X-ray, and echocardiography. And in her case, it was found that her left ventricular ejection fraction was less than 45%, and she did not have any pre-existing heart disease as the diagnosis of peripartum cardiomyopathy was then made. If we follow the rest of it, it is important to note that we should exclude other causes of myopathies, like I already mentioned, pulmonary embolism, amniotic fluid embolisms, and isolated right ventricular dysfunctions. So the principles of management, if we look at the European Society for Cardiology, they recommend that women with suspected or confirmed peripartum cardiomyopathy be managed according to the principles of acute heart failure with a reduced ejection fraction and adapted for pregnancy and lactation safety, and should be coordinated through a multidisciplinary pregnancy team. So this pregnancy team should include at minimum a cardiologist with expertise in heart failure, an obstetrician or maternal-fetal medicine specialist, anesthesiologist, and neonatologist. This, again, in our context, might prove difficult. At the facility that I work at, it is a tertiary level facility, and we are very fortunate enough to have access to all of the above specialists, but that might be limited due to some resource constraints. Maternal stabilization is the primary priority, where fetal considerations, while important, should not delay life-saving medical therapy. And once maternal hemodynamics are stabilized, fetal assessment and obstetric planning can proceed, as was the case with our patient. So management goals include the relief of congestion, optimizing cardiac output, prevent thromboembolism, the suppression of maladaptive neurohormonal activation, and initiation of therapies known to improve long-term ventricular recovery. And then delivery timing and mode must be individualized based on the maternal hemodynamic status, gestational age, and fetal condition, rather than the peripartum cardiomyopathy diagnosis alone. So as with our patient, we proceeded to do acute stabilization following the airway breathing circulation ethos. So the initial management focused on the stabilization of the airway breathing and circulation. We gave supplemental oxygen in the form of a face mask, and then moved on to early non-invasive ventilation in this patient that was in respiratory distress. So intravenous loop diuretics are the first-line therapy and was given to our patient to relieve pulmonary and systemic congestion. Diuretics must be carefully titrated to avoid excess preload reduction and which could compromise our uteroplacental perfusion in pregnant patients. So in hemodynamic stable patients with preserved blood pressures, vasodilators such as nitrates may be used to reduce preload and afterload. Patients with hypertension or evidence of low cardiac output, inotropic agents such as dobutamine are indicated. If hypertension persists, vasopresses may be required. Luckily, in our case, our patient did not need any inotropic support. For patients who remain unstable despite optimal pharmacological therapy, temporary mechanical circulation supports such as intra-aortic balloon pumps and extracorporeal membrane oxygenations can be considered. In our context, we do not have access at this point to extracorporeal membrane oxygenation, thus it was not a consideration in our case. This is just another slide on the initial evaluation. As you can see, we followed the left-sided diagram as our patient was diagnosed with severe peripartum cardiomyopathy. We optimized her preload and opted to give her the loop diuretic furosemide 40 milligrams. We optimized her oxygenation by offering her NIV with PEEP and pressure support. Our patient did not require inotropes or any vasopressors, and we opted for urgent delivery, which was via emergency cesarean section. As you can see, there is a consideration for bromocriptine, but I will discuss that a little bit later. And what is our overall goal? So our overall goal for treatment is to relieve congestion, optimize our cardiac output, prevent thromboembolism, and initiate therapies that would improve long life or long-term ventricular outcome. So as our patient was then recovering, we can then break down the management into our antepartum and postpartum. Antepartum, our heart failure would be our hydralazines and nitrates, and then our beta blocking agents. In our case, we started carvedilol for her as we do not have access to metoprolol. Postpartum, we initiated her on ACE inhibitor. She was on spironolactone, and we did continue her diuretic use. And again, we will discuss later the bromocriptine contention. So the management again can be broken down into our mild, moderate, and severe peripartum cardiomyopathy. And you'll see on the left-hand side, our mild peripartum cardiomyopathy, our oral heart failure medications are indicated with oral diuretics if needed. Moderate, we can initiate again our oral heart failure medications, IV diuretics, and NIV needed, but our patient unfortunately followed the severe management algorithm as already discussed. So what is an easy mnemonic to remember how we should approach the management of a peripartum cardiomyopathy? So we can use the board mnemonic. So board mnemonic, the B is bromocriptine. So bromocriptine targets the central pathophysiological mechanism through the prolactin breakdown into the 16 kilodalton fragment, as already discussed. So commonly used regimes for bromocriptine include for mild to moderate peripartum cardiomyopathy, we can consider bromocriptine 2.5 milligrams orally. That's taken once daily for 7 days. And then severe peripartum cardiomyopathy, those with the ejection fraction less than 25%, cardiogenic shock ICU admission. We can target bromocriptine 2.5 milligrams orally twice daily for about 14 days, followed by 2.5 milligrams daily for a further 6 weeks. It is important to remember that bromocriptine suppresses lactation, and therefore breastfeeding must be avoided. And in a low socioeconomic circumstance or situation, this might not always be feasible. So moving on to the O's, or oral heart failure therapy, which we have already discussed. During pregnancy, safe therapies include our loop diuretics, our beta-1 selective beta blockers, such as your metoprolol and bisoprolol, and afterload reduction with hydralazine and nitrates. So typically starting doses of furosemide is 20 to 40 milligrams orally or intravenously. With our beta blocking agents, the hydralazine dose is about 20 to 25 milligrams 3 times a day, and our dinitrate about 10 to 20 milligrams 3 times daily. ACE inhibitors are ARBs, ARNIs, and our mineral corticoid receptor antagonists are contraindicated during pregnancy because of fetotoxicity. And after delivery, full guideline-directed medical therapy should be initiated as soon as clinically feasible. This includes our ACE inhibitors, which are started for our patient, ARBs, mineral corticoid receptors, or SGLT2 inhibitors. In terms of anticoagulation, peripartum cardiomyopathy carries a high thromboembolic risk due to the severe left ventricular dysfunction, ventricular dilation, pregnancy-associated hypercoagulability, and the bromocriptine therapy itself. The ESC recommends therapeutic anticoagulation in women with ejection fraction less than 35%, or demonstrated intracardiac thrombus, atrial fibrillation, or prior embolic events. During pregnancy, low molecular weight heparin is the anticoagulant of choice. Typically, therapeutic dosing is our enoxaparin, 1 milligram per kilogram subcutaneously every 12 hours. At minimum, prophylactic anticoagulation is recommended during bromocriptine therapy. For our patient, she did receive a low molecular weight heparin post-delivery. The R is then for our relaxation or our hemodynamic stabilization. So acute decompensated peripartum cardiomyopathy is managed according to the ESC acute heart failure algorithms. And this includes oxygen therapy, early non-invasive or invasive ventilation, and intravenous loop diuretics as already discussed. D is for our delivery planning, and all patients should be managed by a multidisciplinary team. In hemodynamically stable patients, a vaginal delivery can be considered, often with an assisted second stage. A cesarean section delivery is usually reserved for obstetric indications or severe maternal instability. The immediate postpartum period is high risk and requires close monitoring. Our patient, due to her severe maternal instability, was taken for an abdominal delivery. So what is the prognosis? So this table summarized pooled long-term outcomes from a meta-analysis of more than 4,000 women and 62 studies with peripartum cardiomyopathy, and a mean follow-up of approximately 4.5 years. Before interpreting the numbers, it is very important to remember that most of these studies were performed in high-income countries. So, starting with our myocardial recovery, approximately 47% of patients achieved recovery, most commonly defined as an ejection fraction greater than 50%. This highlights that recovery is common, but also that more than half of women have persistent left ventricular dysfunction in the long term. So long-term all-cause mortality was about 9%, which is substantial considering the young age of this population. Looking at advanced heart failure therapies, around 12% required implantable cardioverter defibrillators, and around 7% actually required a left ventricular assistant device. Approximately 11% of patients ultimately underwent a heart transplantation, and as I again said, this was in a first world or high-income country context. Overall, the key message from this table is that peripartum cardiomyopathy carries significant long-term morbidity and mortality, where nearly half of women recover their left ventricular function, and a substantial portion actually develop chronic cardiomyopathy, which require advanced therapies or demise. So, reinforcing the need for lifelong follow-up and careful counseling of these patients. So having a quick look at the South African context, we unfortunately have very little data in the South African context. There was about a prospective South African cohort of about 176 patients, where only 21% had recovery of the left ventricular function at 6 months, which is substantially lower than the high-income countries, which reported a 47% chance of recovery. While approximately 26% experienced a poor outcome defined as death or persistent left ventricular dysfunction. So this recovery rate, as I said, is substantially lower than the reported in many high-income countries. So a subsequent registry in South Africa compared to German patients that showed similar findings, with only 32% of South African women recovered in that 6 months, compared to over 50% in the Germany cohort. Mortality in South Africa group was around 11%. At the population level, national maternity mortality audits demonstrate that peripartum cardiomyopathy is a leading cause of maternal death in South Africa, and accounting for approximately 1/3 of all cardiovascular maternal deaths. Together with this data, it highlights that outcomes in South Africa are poorer than in high-income settings, reinforcing the importance of early recognition, rapid referral, and access to multidisciplinary care. So a quick note on bromocriptine. So the current management of peripartum cardiomyopathy centers around standard directed medical therapy for heart failure with reduced ejection fraction, as we've already noted. The discovery of prolactin as a potential mediator of peripartum cardiomyopathy has motivated interest in investigating prolactin inhibition as a potential target. Bromocriptine is, as we know, a semi-synthetic ergot alloid or alkaloid that is a potent agonist of the transmembrane G-coupled protein dopamine 2D receptor, what a mouthful, and various serotonin receptors in the central nervous system. It is administered orally with a very low bioavailability of about 10%, because there is a considerable first-pass metabolism. So bromocriptine is highly bound to albumin and metabolized via the cytochrome P450 system, and is mainly excreted by the liver, and it's been successfully used in various diseases such as prolactinoma, galactorrhea, and type 2 diabetes. Recent research supports and encourages the use of bromocriptine in peripartum cardiomyopathy because of its ability to block the prolactin release from the pituitary gland. So what does the evidence say? So again, the evidence largely comes from our high-income countries, and this data collected is from the European Observational Research Program Registry, which included over 500 women with peripartum cardiomyopathy, where 85% received bromocriptine in addition to standard heart failure therapy. The primary outcome was death, heart failure, readmission, and persistent dysfunction at 6 months. So this occurred in about 22% of women treated with bromocriptine compared to the 33% without. So after adjustment for baseline differences, bromocriptine was associated with about a 53% lower odd of adverse maternal outcome. Similar results were seen across different statistical models. So the benefit is mainly driven by fewer women who remain with severe left ventricular dysfunction, supporting bromocriptine as a disease modifier adjunct to peripartum cardiomyopathy treatment. This meta-analysis from Kumar et al. Looked about 750 patients, of which 270 were included from studies reporting the ventricular ejection fraction at follow-up. And at follow-up, it ranged from about 6 to 12 months, and with both cohort and randomized controlled trials showed an improvement of the ventricular recovery about 2 to 14%. The left ventricular recovery in about 5 studies looking at 390 patients also looked at the recovery and showed that bromocriptine use showed a greater odd of left ventricular recovery. Systematic reviews and meta-analysis demonstrated that the addition of bromocriptine to the standard treatment is associated with significantly improved in left ventricular ejection fractions at follow-up. In addition, they also found that the odds of left ventricular recovery was higher in the bromocriptine group. So in terms of the dosing, there were a few variations across studies ranging from about 2.5 to 5 milligrams per day for 4 weeks and then to 2.5 milligrams daily for 2 weeks. If we have think about, does the dose even matter? So there were 2 dosing regimes, so a short course of a week, so 2.5 milligrams daily for 7 days, or a prolonged course, 5 milligrams daily for 2 weeks, and then 2.5 milligrams daily for 6 weeks. This randomized controlled trial was multi-centered and compared these 2 regimes, and both of the groups have substantial improvement in ejection fraction at 6 months with no statistical significance between the differing regimes. However, a higher portion of women in the 8-week group achieved full recovery, although this was not statistically significant. Importantly, there were no death transplants or assisted devices or assisted device implantations in either group, and bromocriptine is thus added to the standard heart failure therapy was associated with higher rates of recovery and excellent short-term outcomes in peripartum cardiomyopathy with no clear superiority between the short or the long course. So how would one manage a future pregnancy in a patient with peripartum cardiomyopathy? So this figure summarizes counseling and management of women with prior peripartum cardiomyopathy and subsequent pregnancies. So first, prognosis is heavily influenced not only by our cardiac function, by also the general maternal and health system factors such as extremities of age, poor education, low income, long distance to care, and late presentations. The key decision point is the left ventricular recovery. So women with partially or fully recovered left ventricular function, defined as ejection fraction above 50%, qualify or fall into our low risk profile. However, relapses remain possible. The risk of heart failure death is generally below 10% in this low risk group, and fetal outcomes are usually good. So pregnancy may be considered in this group after careful counseling, but they must be adequately counseled on the risk and managed as a high-risk pregnancy. So in contrast, women with poor recovery, so that is on the right side of the diagram, meaning ejection fraction below 50%, have a high risk of relapse, heart failure and death exceeding beyond the 10%, as well as an increased risk of prematurity and fetal demise. Pregnancy should therefore be strongly discouraged, particularly if the ejection fraction is below 30%. Across all patients, management requires multidisciplinary care, referral to experienced centers close monitoring with monthly echo, careful postpartum care, and early contraceptive counseling, as recovery improves prognosis but does not eliminate the risk. So if we have a look on the left-hand side, so that would be our low-risk group, our relapse in that subset of patients is about 1 in 4. And then in our high-risk group on the right-hand side, you can see that the relapse risk is about 1 in 2. So as contraception, so contraception is critical with women with prior peripartum cardiomyopathy, and pregnancy carries a substantial risk. So even in women with recovered ventricular function, relapses occur about 20 to 30% of patients. Contraception options to avoid would be our estrogen-containing contraceptions, as they have got a high risk of venous thromboembolisms. Our preferred first lines is usually our long-acting reversible contraceptive options, so our progesterone implant or our progesterone intrauterine contraceptive devices. So that brings me towards the end of my talk. I hope everybody enjoyed it and that the management and approach of peripartum cardiomyopathy is clear. Nancy, I hand over to you. Oh, Nancy, I think you are muted.
Sorry, thank you so much. Very extensive, but thank you so much for giving us such a broad insight about peripartum cardiomyopathy. We have with us Dr. Taslim Hassim, who is giving us the expert opinion, specifically in the South African context. Dr. Hassim is as I said, an alumni of Tygerberg Hospital, Stellenbosch University, along with myself and Dr. Janse van Rensburg. She's currently subspecializing in maternal-fetal medicine. And she is giving us our expert opinion tonight. Dr. Hassim.
Good evening. Good evening, everyone. I hope you can hear me. And thank you to Nancy for the kind introduction. And thank you to Dr. van Rensburg for the wonderful presentation. So I'm just going to give some key principles on the management of peripartum cardiomyopathy, especially in the context of a low-middle income country. And then I'm just going to touch on a few nuances in the differences in a low-middle income country as opposed to a high-income country. So unfortunately, medical and surgical, yes.
We do have a few questions. Do you want to start with questions, or do you want to? Is that okay? If we can ask, if we just address some of the questions.
Yes, yes, of course.
We have a question from Kamuhelo, who says, "What is the consensus on bromocriptine use in hypertensive disorders?" And also one from Mokwena, who says, "Does ejection fraction of more than 45 completely exclude the diagnosis of peripartum cardiomyopathy?" We'll start with those two.
So I'll start with the second question first. So we know that the definition of a peripartum cardiomyopathy includes a left ventricular ejection fraction below 45%. So an ejection fraction more than 45% doesn't entirely exclude the diagnosis. You obviously have to look at your history, your examination, ask yourself in context of the patient, because the patient may actually present with significant symptoms before the ejection fraction drops. Also, we know that we have an overlap with preeclampsia and pulmonary edema, and we know that in our preeclamptic patients, they more often have subclinical myocardial dysfunction in the form of diastolic dysfunction. So the patient might most likely have early onset peripartum cardiomyopathy, but don't just think about peripartum cardiomyopathy. Think about preeclampsia with pulmonary edema and diastolic dysfunction. Think about fluid overload, and think about hypertensive heart disease or your other differential diagnosis of your patient's presentation. And then with regard to...
Sorry, Dr. Sam,
yes.
Do you mind just showing us the case again so that we just have this idea in our mind as Taslim answers the questions? Thanks. Sorry, Taslim. Sorry to cut you off.
No, it's okay. So the second question was, what was the second question? Looking at the use of bromocriptine in hypertensive disorders. So there's no universally standardized use of bromocriptine in hypertensive disorders. It's specifically used for established peripartum cardiomyopathy, and the evidence is for the severe category with an ejection fraction of less than 25%, or if a patient was admitted to the ICU, or if the patient presented with cardiogenic shock, because we know that the pathophysiology is due to the production of the toxic metabolite, and this is what bromocriptine is addressing. So it's not specifically used for hypertensive disorders without peripartum cardiomyopathy. Remember that bromocriptine itself can drop your blood pressure as a side effect. That is rare, but it can also precipitate a hypertensive crisis, but that is also rare. So you have to be very careful in a hypertensive patient, and you have to monitor them very carefully. So in summary, no, it's not universally standardized for hypertensive disorders. Its main use is for peripartum cardiomyopathy, and specifically due to the pathophysiology.
Thank you. So you've worked in the critical care unit at a tertiary level facility at Tygerberg Hospital. And what is your experience in the management of peripartum cardiomyopathy, specifically in the South African context? And how have you had to adapt the standardized guidelines to address the issue in the South African context?
Yeah, so it is quite difficult when you compare the guidelines in the European guidelines and what we have available and our available resources in a low middle income country. We know that peripartum cardiomyopathy falls under medical and surgical disorders, and this is actually the top cause of maternal death, specifically in the Western Cape, and the second commonest cause of maternal death in sub-Saharan Africa. It's life-threatening, but it can be managed, and it is potentially reversible. So what I've learned that actually early recognition is very, very, very important. So you should never ever shortchange or underestimate the power of a good history and examination. Always have the red flag symptoms at the back of your mind. If a patient presents with worsening shortness of breath, orthopnea, a tachycardia that's not in keeping with the clinical diagnosis, if something doesn't make sense, ask yourself why. Always, no matter, I always teach this to the registrars, no matter what patient you are faced with, follow the basic principles of resuscitation and stabilization. And it's important to keep calm because a hypoxic patient doesn't need a hypoxic doctor. Remember in our population that the diagnosis of PPCMO is if there's no other identifiable causes. So always try and look for an alternative cause, and especially in our population, rheumatic heart disease and HIV associated. And also look for the contributing factors, especially in a low middle income country. And preeclampsia is often an overlap in our population. And Thomas attributed this to the angiogenic factors, the increased S-FLIT, the genetic predisposition, the baseline risk of untreated hypertension, endothelial dysfunction. And in low middle income countries, the burden of preeclampsia is much more severe and it presents much more earlier. So essentially, if you are faced with this patient, you follow your basic principles of management of acute heart failure. In terms of investigations, we don't really need a pro-BNP. It's nice to have, but it's expensive. It's not always available. Manage the patient that's in front of you. In terms of doing an ECG, we know that it can be normal, but it can help you in order to look for your differential diagnosis. So in our setting, we are fortunate enough to have an excellent cardiology team. So we have access to bedside echoes very easily. But if you don't have this available, upskill yourself in focused ultrasounds. And if you have a clinical diagnosis and a bedside focused ultrasound, you just follow the general principles of the management of heart failure. Look at your patient. How is she breathing? And we always try and say this, try and breathe with the patient. If your patient has a rest rate of more than 25, saturation of less than 92, or accessory muscle use or acute pulmonary edema, transfer her to a higher dependency unit. It doesn't have to be a high care unit. Put her in the left lateral, administer a diuretic and oxygen support. And if you have available non-invasive ventilation or CPAP, and this will help you to avoid the need for intubation, because we know that ICU beds is a limited availability, especially in the low resource setting. Another big issue is the use of betamethasone and steroids for fetal lung maturity, especially if you are faced with a patient that is less than 34 weeks with impending preterm delivery. We know that betamethasone itself can increase your mineralocorticoid activity, and this can actually precipitate pulmonary edema. It can worsen pulmonary edema, and it can tip your patient over into cardiogenic shock. So you have to balance this against the limited availability of NICU beds and the burden of neonatal respiratory distress, especially in the low middle income countries. We know that betamethasone has added benefit effects. That external surfactant is unfortunately not going to be a benefit. Another big thing that we are faced with is the use of bromocriptine. And we have good evidence from South Africa, where Prof. Karen Silva from the University of Cape Town showed that there is an overall improvement in mortality and ejection fraction, but this is solely used for those with severe peripartum cardiomyopathy and cardiogenic shock. The issues in our population is thrombosis. We know that the WHO endorses exclusive breastfeeding. We know about the benefits of breastfeeding and the high neonatal morbidity associated with formula feeding, the burden of HIV, and the cost of formula. And donor milk is not always available, and the cost and access and adherence in our patients is not really a reality. So essentially, your aim is to stabilize your patient and deliver your patient. Delivery is as per standard obstetric indications. So unfortunately, in our setting, we don't have the availability of LVADs or ECMO or potential cardiac transplant. So there's no real role for expectant management in our patients. So we want to stabilize, deliver, and prevent complications and further progression, because we don't want our patient to end up requiring a cardiac transplant or ECMO, because this is not, unfortunately, available in our situation. It's important to have a good anesthetic team. Unfortunately, if your patient is in New York at 3 to 4, she's in acute heart failure. Yes. Yes.
There's a question just surrounding what you're speaking about. So when do you decide timing of delivery and mode of anesthesia in unstable mother with postpartum cardiomyopathy? Are there any biomarkers that can help predict the progression of the disease and the severity of the disease at the present state?
So, like I alluded to, because peripartum cardiomyopathy generally occurs in the latter half of pregnancy, so it's usually in the latter half of the third trimester postpartum, there is no real room for expectant management, especially in our population, because of the overlap with preeclampsia, firstly, and secondly, we want to halt the progression of the disease. And we don't want any more further progression of the disease where your patient might be in cardiogenic shock or requiring an ICU admission. So there's no real role for us in terms of expectant management. Essentially, your aim is to get the patient in the best possible hemodynamic state before you deliver her. Because remember, during delivery, you're going to have the catecholamine release, the tachycardia, blood pressure fluctuations, and this can further exacerbate pulmonary edema and then tip her over into cardiogenic shock. So diurese your patient, give your patient some NIV or CPAP, try and get the patient out of pulmonary edema, get her blood pressure stable. Be careful with inotropic support in these patients, because remember, peripartum cardiomyopathy is a pro-arrhythmogenic state. Once your patient is stabilized, she has a pH above 7.3, her PO2 is above 10, her respirate rate has come down, her heart rate has come down. You have an anesthetic review, because remember, your patient must be stable. If you're going to deliver her, she must be stable enough to have an anesthetic. The mode of delivery is essentially going to be determined, number one, by your obstetric indications and by your clinical assessment. This is highly individualized. There's no guidelines to tell you. What we do know is if your patient is a New York Heart 3 to 4, if she's acutely short of breath, if she's an acute heart failure, you will rather opt for her to have a combined spinal epidural or graded epidural and a gentle cesarean section. Early markers that can help you to predict PPCMO before overt symptoms. I think this is more useful in a patient that had a previous peripartum cardiomyopathy. She's now pregnant again, and you're monitoring her for, number one, decompensation or a relapse. So what you can use, there is a role here for the use of proBNP. So there's no essential absolute value that can be used for proBNP, but when your patient presents to you for the first time, you can firstly do a New York Heart status, you can do a baseline proBNP, you can do a walk test, a baseline clinical exam, and a baseline echo. And then you slowly follow her up, and then every 2 weeks you can repeat your proBNP. If you see that your patient is becoming more short of breath when you're doing the walk test, if a heart rate is slightly creeping up, if a saturation is slowly dropping, or resp rate is slowly creeping up, and the trend of the bromocryptine is in a higher level than what it was previously, these are early markers that we use to help predict, and then we would admit the patient, stabilize, and deliver this patient. So I think there is room to use the biomarkers in a patient that had a previous peripartum cardiomyopathy, but there's no real room to use proBNP in a patient with acute peripartum cardiomyopathy. And timing of delivery is essentially once you have your patient in the best hemodynamic state, the patient has been reviewed by anesthetics, and she is able to undergo an anesthetic. Remember, not all of these patients require a cesarean delivery. They can have a vaginal delivery with an epidural in a high care unit with continuous monitoring if they are stable enough to tolerate a vaginal delivery.
There's a question, Dr. Hassim, on the use of magnesium sulfate in the initial stabilization. So the question is the understanding overlap between the PPCMO and preeclampsia and also the concern of further fluid overload. Is there any evidence for the use of magnesium sulfate in peripartum cardiomyopathy? I'm not sure if it's in the context of eclampsia prevention, but that is the question. Is there a use of magnesium sulfate?
Yeah, so there's no routine use for magnesium sulfate peripartum cardiomyopathy itself. It should essentially be used as per standard indications for your patient that has an overlap with preeclampsia. For example, if she has eclampsia to prevent further seizures, or if she has signs of impending eclampsia, or if she has preeclampsia with severe features. Remember that magnesium sulfate itself can cause hypotension and vasodilatation and negative inotropic effects, as well as respiratory depression if your patient becomes magnesium toxic. So be very careful when administering it in a patient with acute peripartum cardiomyopathy. What you can do is you can fluid restrict your patient. You can give it via an infusion pump. And what we specifically do in our high care unit is that we mix it in a bag so that you give less fluid volume to the patient. So we'll take 8 grams of magnesium sulfate, we'll put it in 200 ml of normal saline, and we'll give it at 25 ml an hour with no other added fluids. We'll monitor the patient for signs of magnesium toxicity. So you monitor their resp rate, you monitor their urine output, you monitor their reflexes, and you monitor their saturation. So in that way, it can actually be a safe use. Remember that also the benefits of magnesium sulfate. You can stabilize your blood pressure. Firstly, it's an antiarrhythmic because remember, peripartum cardiomyopathy is a pro-arrhythmogenic state. It's neuroprotective, both for the mom and for the fetus. So it does have its benefits. You can use it if you have an overlap with preeclampsia and there is a definitive indication, but you can use it in a more restricted form, and you can mix it in at 25 ml per hour and restrict further fluids.
Thank you. In the beginning of the talk, Dr. Janse van Rensburg mentioned that South Africa has an incidence of 1 in 1,000, which is the highest outside of West Africa. Is there anything that's being done in West Africa that we've adapted to the use or the management in South Africa, given that they have quite a high incidence of peripartum cardiomyopathy in the African context? Do you know?
I don't, but if there's anyone that is from West Africa, maybe they can actually give us some insight.
Otherwise, going back to our case, while we wait for somebody from West Africa to let us know, can you just give us some from the presentation, or just from who the patient is, what are the early signs that we should be looking out for, especially in a limited resource setting where we should pick up signs early to prevent, as you said, severe morbidity and the risks or the need for transplantation and ECMO and things we have no capacity of helping our patient with?
I think Dr. van Rensburg can answer, then I'll just add on to the answer.
So if we specifically look at our case, how she presented, we can immediately see from our history taking that there are a few risk factor and red flags that we can identify. So number one, we can see that she is of young age. We can see that she's currently in this pregnancy got a set of DCD8 twins, which does increase her risk for cardiomyopathy. It was not mentioned here, but she is of African ancestry, so that alone increases her risk by 3 to 16%. If we then further look on our history, so she does have acute onset shortness of breath, which should immediately start allaying red flags as to, might this patient present with some form of heart failure. If we look at our initial investigations, we can already see our pulse is increased. We can see that our saturation is low and that our respiratory rate is high, which in itself is already a flag. On the clinical exam, we can see that there is some form of fluid overloaded state with the crackles that we can see on our respiratory exam and the displaced apex and the S3 gallop. And then in our chest x-ray, we can appreciate that there is an increase in cardiothoracic ratio with this significant pulmonary congestion. Given this context and the fact that she's got no pre-existing medical disease, I think we've ticked already quite a few boxes that might, raise that flag that does this patient have a peripartum cardiomyopathy or any cardiomyopathy for that fact. The only thing of note is that she had acute severe hypertension and trace proteinuria. So that does tie back to that possibility that is this maybe a preeclampsia patient with pulmonary edema? And we need to further explore that. And then just going through it, having a look at the echo, we can see that echo is striking. Her left ventricular ejection fractions are less than 20%. It's less than that 45%. This puts her in some form of severe category. And we can see that left ventricle is severely dilated with severe systolic impairment. As we've already alluded, left ventricular dilation is not a key diagnostic thing for peripartum cardiomyopathy, but it does add another little chip in our hat that might say this is peripartum cardiomyopathy. So I think just given how this patient presented, we do have a few risk factors. We have got this possible preeclampsia overlap. There is this clinical exam that points towards some form of fluid overloaded state that we need to go and weed out, what is causing her fluid. Is it cardiac of origin? Is it endothelial dysfunction? Is it preeclampsia overlap? So this is actually, a hot pot of possible things that's going on with this patient.
Thank you so much. We have an interesting question from Olivier. He's asking about the use of pyridoxine or I suppose in this context, maybe carbagoline that's more cardiac stable in the use of patients where bromocriptine may be an issue to try and suppress lactation as a substrate or an alternative method for management of peripartum cardiomyopathy.
So,
Yeah, so I think cabergoline is, and sorry, Thomas,
no, no,
cabergoline
you can go on.
an excellent alternative to bromocriptine. We know that number one, it has less side effects than bromocriptine, and it's a weekly dose, so we'll have better adherence. The issue is that theoretically, it will have the same effect as bromocriptine, better patient adherence, less side effects, but we don't really have enough data that compares bromocriptine to cabergoline and its benefits over bromocriptine with regard to myocardial ejection fraction improvement and overall mortality. But theoretically, yes, it can be used as an alternative. I know that there is a study that is happening in Canada that is looking at comparing the use of bromocriptine and cabergoline and which one is superior. I don't think we have the results as yet, but that it would be actually very nice to see what the results of that study is. In terms of pyridoxine, I can see where we can get that idea from. Essentially, pyridoxine, you can theoretically, it's used to suppress lactation, but there's no real evidence to show that it does reduce the toxic metabolite of the prolactin. We don't really have any trials showing that it improves the overall mortality or ejection fraction. So it is used to suppress lactation, but not in the same way that we would use bromocriptine or cabergoline. I think if we do have evidence in the future, it is a nice alternative because it is much cheaper and less side effects again. But I think the better alternative for pyridoxine will actually be cabergoline. And it can be used, it should be used. It's just that we don't have the evidence that compares the use of bromocriptine and cabergoline. I don't know if Thomas has anything more to add to that.
No, thank you, Dr. Hassim. That is exactly what I wanted to reference is that Canadian study, as far as I also know, is the only one that is currently investigating it. As far as I remember, we should have some results by the end of 2026 to 2027 mid. So we'll see what the evidence shows.
All right. I will have one more question. It is 2018. We have been here for a while. Very informative. We've had quite a good, very interactive discussion. Thank you so much for your participation. Chindima, if you would like to address us, I think, are you from West Africa? Chindima?
Hello, Nancy. Yes, I'm
Hi.
from West Africa. I'm not, my hand is not up to address that
Oh.
question as I have no statistics to provide. I have a question. Beautiful presentation. Thank you so much, Thomas, and thank you everyone that's contributed so far. My question is now relating it back to, this is an African forum. We have diverse population, diverse attendees from different parts of Africa. It's beautiful that South Africa has almost everything necessary to arrive at a diagnosis. My question is, how should a clinician who finds themselves in a resource extremely limited setting where echocardiogram is not available, you have a patient presenting with symptoms suggestive of peripartum cardiomyopathy. We are well aware that pulmonary embolism shares very, very, very close symptoms and signs as PPCM. The clinician has no access to echocardiogram or any form of advanced imaging. Can you explicitly maybe state certain unique signs that one would use to note or differentiate between PPCM and pulmonary embolism to aid decision on referral to a higher center? Thank you.
Thank you.
An excellent question. I'll let Thomas start and then I'll add if there is any addition.
Yeah. I think the nuance in this is that what Dr. Hassim also spoke about earlier is that we should not fall into the trap of relying on special investigations to make the diagnosis. Yes, it is there as an aid, but I think we should always fall back into what does your patient present with? What are the signs? What are the clinical features? What do you find on your examination? And then treating the signs and symptoms that you have, in front of you. If we take the general management of peripartum cardiomyopathy, the cornerstone or the foundation is that we manage it as we would a patient in heart failure. So if we take that premise, a patient that would present in this type of thing where she does have symptoms and signs of heart failure, we aren't 100% sure what that underlying cause might be. It might be that she's got a pulmonary embolism with high pulmonary pressures and right ventricular dysfunction and atrial dilation that then pushed her into failure. But the principle is still that we are going to manage her as if she has got heart failure, and then take it from that point of view and then initiate our heart failure treatment. Lots of the things that have, underlie the management of pulmonary embolism also underlines the management of peripartum cardiomyopathy, in the fact that, if the pulmonary embolism is so big that it contributes to heart failure, would manage them the same. In terms of anticoagulation, both of them we would anti-coagulate, as peripartum cardiomyopathy in itself also has got a very high risk of thromboembolism and arrhythmias, as Dr. Hassim already said. So I think, if you do not have availability to an echo or to a VQ scan or to a CTPA to help guide us, I think we should still initiate the basic treatment of, we've got a patient, she has these signs, these symptoms, this is her clinical examination, and then we subsequently treat her according to what we find on our, clinical examination. I don't know if Dr. Hassim has got any other viewpoints or advantages on this.
No, that was an excellent summary. So like I said, in my part of the talk, you should never, ever, ever shortchange or underestimate the power of a good history and a clinical examination. Always look at the red flags. Is your patient's clinical picture in keeping with just a pulmonary embolus, or is there something added? Does something not make sense? So on your examination, because we have such a broad overlap with preeclampsia, look at your patient's blood pressure, look for proteinuria, look at the heart rate, look at the saturation. When you examine her, does she have hyperreflexia? Does she have signs and symptoms of imminent eclampsia? Does she have clinical signs of pulmonary edema? So whatever patient that you are essentially faced with, doesn't matter where you are, if you follow your basic principles of history, examination, look for your red flags. Like I said, look at the shortness of breath. Is it in keeping with your picture? Is the orthopnea in keeping? Is the heart rate in keeping? Is the saturation in keeping? Is your clinical exam in keeping? Look at the patient. How is she breathing? What is the rest rate? What is the saturation? Is the accessory muscle use? Whatever patient that you are faced with, follow the basic principles of resuscitation. Also remember that our patients are not textbooks. Our patients can present with multiple comorbidities and multiple overlapping syndromes in one. You might have a patient that presents to you with signs and symptoms of acute heart failure with a raised JVP, bipedal edema, hepatomegaly, ascites, signs of pulmonary edema, but she may also have an exorbitant tachycardia. She may have S1Q3T3 on an ECG. She might have added risk factors for a pulmonary embolus. She might have bronchial breathing. She might have a productive cough. So your patient might actually have acute heart failure, an acute PE, as well as a lower respiratory tract infection, all in one. And also we must never forget about pulmonary TB, especially in our population that has a burden of HIV. So if you follow your basic principles, resuscitate your patient, put up a line, diurese your patient, oxygen supplementation. If you clinically suspect that this is an acute pulmonary embolus, start her on a heparin infusion, because remember, If you're going to deliver, you can always stop it 4 hours before. You can restart it after, stabilize the patient, get it to a higher level of care, where you can actually confirm your diagnosis or refute your diagnosis, and you can always change your therapy as it is. You can always start antibiotics as the sepsis guideline says, do your cultures. If you want to downscale your patients at a higher level of care, if there's no evidence when you do a chest x-ray or when you send your sputums, if there's no evidence of infection or viral infection like H1N1, you can always downscale your management. But rather, when you are faced with the patient, focus on what you see on history and clinical exam and treat according to that and follow your basic principles of management. And you shouldn't go wrong with doing that.
Thank you so much, everyone. Thank you so much for joining for the inaugural Watog case series presentation. For those of you who don't know, Watog is the World Association of Trainees for Obstetrics and Gynecology, and it's a community aimed at bringing together trainees from all over the globe. And we work to exchange ideas and our training protocols for trainees in obstetrics and gynecology to expose us to, as what we've done today, cases that better our understanding of patients in obstetrics and gynecology. Thank you all for joining. We will have another session in 2 weeks' time on a Saturday. Watch out for that. But thank you again for your participation. Thank you, everyone.
Good. Thank you, Dr.